Milestone Intracranial hemorrhage and cocaine addiction. The origin of cocaine. Cocaine is derived naturally from the alkaloids of the cocoa plant, which comes from South America. One significant negative consequence of chronic use is intracranial hemorrhage. Cocaine causes an increase in blood pressure and vasoconstriction. This means that cerebral vasculature ruptures easily. Chronic use of cocaine can also induce seizures and structural changes in the brain. One pharmacological aspect to consider with cocaine when consuming it in large quantities is that the blockage of norepinephrine reuptake is very potent. This induces an intense sympathetic response. The effect is that there is now an increased chance of the things listed below and stroke when large doses are taken. It has a very strong euphoric effect because the dopamine reward pathways are being highly activated. The effects of the high wear off quickly. This programs the brain to crave it more in a short period of time. Young adults are a vulnerable population regarding cocaine use disorder because cocaine use typically starts in late adolescence to early adulthood. This time frame coincides with neurodevelopment and increased risk of taking behaviors. National survey data points to 20 years as the median age of starting cocaine use in the U.S. Early exposure leads to higher likelihood of becoming dependent on these substances, using other substances, and facing long-term health consequences. The medical complications that occur in chronic cocaine use are typically common in young adults. Cocaine is the effects include hypertension, vasoconstriction, and increased risk of cerebrovascular and cardiovascular accidents. Studies have also revealed that there is a significant association between cocaine use and both ischemic and hemorrhagic stroke in young adults who don't have typical cardiovascular risk factors. Moreover, cocaine-related hemorrhage and other neurological sequelae are major contributors to the mortality in young adults. The U.S. drug policy focused on decriminalization through innovatives like the War on Drugs and Anti-Drug Abuse Acts of 1986 and 1988. These policies formed in these ordinances that increased penalties for possession and trafficking, which address the downstream effects through law enforcement. However, this does not address the underlying issue about preventing cocaine use in the first place, nor does it treat the disorder. In spite of these policies, cocaine is still available, and data shows that there has been an increasing frequency of cocaine abuse in the U.S. Recent policies regulated cocaine through its Schedule II classification dictated by the Controlled Substances Act. This does not factor in the increased production and trafficking of cocaine occurring on an international scale in spite of enforcement attempts. Treatment access for individuals with cocaine use disorder have been limited because addiction was addressed through the criminal justice system instead of being treated as a medical condition. This is a major public health issue that typically never received that approach when it comes to resolution. The stigma surrounding substances and the significant gaps in insurance coverage are both barriers that make accessing care difficult. More recent policies like the Mental Health Parity and Addiction Equity Act of 2008 and the Affordable Care Act of 2010 expanded insurance coverage for treatments addressing substance use disorders, as well as increasing access to mental health treatment services across this age group. In spite of these improvements, there are still many barriers to care, which include a specialist supply gap, financial constraints, and the stigma behind getting treatment. Research shows that the individuals who begin using substances such as cocaine at younger ages are more likely to develop substance use disorders, which further emphasizes the need for early intervention treatment programs that are inaccessible. Moreover, further studies reveal that the high risk of cardiovascular and neurological sequelae such as ICH further underscore the need to integrate addiction treatment with medical care to avoid recurrent adverse health issues. Tolerance describes how the body adapts to the presence of a drug. In cocaine, tolerance appears as the depletion of presynaptic dopamine stores in the chemical changes of the receptors themselves. A helpful policy change that could greatly impact the harm reduction is an expansion of screening and intervention programs that are affordable for the population. By setting this intervention program across colleges universities, and community clinics, there is a higher chance of early intervention occurring. Since cocaine use commonly begins around the age 20, being able to identify at-risk individuals and provide treatment before the use progresses into the dependence and other health complications. These programs can include substance screening, mental health services, counseling, peer support. Expansion of access to these services can reduce the incidence of stroke, ICH, and cardiovascular disease, which typically impacts young abusing cocaine adults, despite the low baseline risk for these conditions typically. Forcing the policy to shift its focus to therapeutic measures instead of punishing allow harm reduction to still occur effectively, which would lower the overall related healthcare costs. More assessments and research on effective harm reduction methods need to be further investigated. There's an understanding of what might work well, but the current policies do not align with the needs of the population since they only address downstream effects when the damage is done. More research needs to be done on effective prevention and harm reduction methods to prevent the cocaine abuse so that the incidence of ICH and other cardiovascular sequelae can be reduced. Here are my educational resources and references. Thank you.